Hey, good morning, everyone, and welcome to UroNurse. I'm your host, Vic Senese. Welcome to the show. If you're watching us live, we're coming to you on YouTube, Facebook, X, LinkedIn, and Kick. So any of those are perfectly fine to watch us live. Although you X viewers, you can't put any comments or questions in. That's the only drawback. So if you want to give a comment or question, go to some of our other things on our website. Speaking of our website, if you're new to the show, be sure to check it out at uronurse.com. Best place to learn more about the show. Also, we have some other great podcasts you might want to check out. We've got a bunch of great advertisers that are helping to support the program that you can go and check out their website. So check out our website. Today, we've got a great episode. We have 153 episodes that you can check out that are our past episodes. So go to our website, best place to find all of those. And we also make an audio podcast out of every episode. So if you want to listen in your car, go to Apple Podcasts, Spotify, iHeartRadio, Amazon Music, and YouTube Music, all those places. The neat thing is, like, I like to listen sometimes. I don't always catch them all. I'll go to Apple Podcasts. I subscribe to a podcast and it shows up in my box as soon as it's there. So great place to go. Now, today we've got a great show for you. It's going to be on sexually transmitted infections, essential knowledge for healthcare providers. It's given by Kirsten Trudeau, who's an MSN, APRN, family nurse practitioner, and STI educator. So we're going to be looking forward to it. This is going to be kind of an interesting, we're going to do a group of 3 of these, not in a row. We have one regular show coming up next week, but the rest will finish up. It's going to give you a total of 2.75 contact hours, but you can put in for each of these contact hours separately. So that's really the best thing about these shows is I think they give a great education. Plus those contact hours are kind of nice. So today's will be worth one. You'll be able to go to the website, find a little button you click to get your providers your contact hours. You have to take a little test, but simple as can be. And if you've watched our show before, you've probably done some of these. So this is a live show. I'm actually here live. So if you have any questions or comments, you can go ahead and put those into the comment box, or just let me know where you're watching from. I'll come on at the end of the show and we'll talk some more. But anyway, let's get on with.
Hello, and thank you for joining for another KYIP Training Center Continuing Education module. Today, we're going to be talking about a two-part module, with Module 1 being one part, and then Module 2 has 2 parts. And so this module will cover sexually transmitted infections, essential knowledge for healthcare providers. And I'm Kirsten Trudeau. I'm one of the nurse practitioners here at the Kentucky Infection Prevention Training Center, and I'm so glad to be talking to you today about this information. Funding for this presentation was provided by the Kentucky Department for Public Health. Content includes discussion of unlabeled use of products. I have no financial interests or other relationships with the manufacturers of products, and no commercial support was provided for this educational activity. So our objectives today are to review STI epidemiology in the United States. We'll identify and describe chlamydia, gonorrhea, and MGen, apply a patient-centered approach to STI care, and determine appropriate screening, testing, and treatment for each infection. So what is a sexually transmitted infection? STIs are illnesses caused by bacteria, viruses, fungi, and parasites, which are transmitted via sexual contact. So these can be these illnesses don't always have to be sexually transmitted. They could be transmitted other ways, and some examples of these would be Oropouche, Zika, Ebola, Mpox. And understanding transmission and taking a good medical history will help you decrease that stigma around STI transmission. So what is the impact of STIs and HIV? These types of infections are directly and indirectly related to health consequences. There is a stigma around these types of infections, which makes it really hard to talk about in certain instances, particularly when you're trying to get a history from a patient. There can be pregnancy complications, there can be infertility issues, cancer, drug resistance, and these diseases can lead to lifelong effects. There's a high cost to the healthcare system, and some of these can even cause death. And also, there's the public health concern related to these infections as well. So here's kind of the sexual healthcare history timeline, and this is a nice timeline from the CDC. So you can see here in 1943. So this is when penicillin was first used to treat and cure syphilis. So this is many decades ago. And then from 1943, we didn't really see a whole lot as far as like recommended treatment schedules go until about 1972. And then they had the first recommended treatment schedules for gonorrhea that was published in the CDC's MMWR. And then in 1982, there was the first comprehensive CDC treatment guidelines for STDs published in the MMWR. And then in 1989, we started to have that issue with increasing resistance. Penicillin and tetracyclines were no longer recommended to treat gonorrhea and chlamydia. And so ceftriaxone plus doxy was recommended for uncomplicated gonorrhea. And so this is really important to remember as we continue to talk about gonorrhea further in our lessons here with STIs. And so between 1989 and 1993, the STD treatment guidelines evolved kind of from a quick reference guide on treatment to more comprehensive care to provide patient-centered care. And then in 1993, fluoroquinolones became one of the recommended options for GC treatment. And so from 1990s to early 2000s, the STD guidelines went digital with their first website established, making all of that content freely available, which was really important in the treatment of these illnesses. And so in 2006, the STD treatment guidelines expanded to discuss the management of asymptomatic persons for STDs, which is also really important when you are thinking about transmission and partner treatment and things like that. So in 2007, fluoroquinolones were no longer recommended for GC treatment, and then cephalosporins became the backbone of GC treatment. And then in 2010, there was an STD treatment guideline that was a pocket guide and wall chart was created, making things more accessible, more readily available for the treatment of these diseases. In 2012, ceftriaxone only was the only recommended antimicrobial to treat gonorrhea. In 2013, STD treatment guideline an app was created to allow more providers access to the guidelines. And then in 2015, the last full edition of STI treatment guidelines was released. And there is a current STI treatment guideline on the CDC's website that is very comprehensive for providers to follow. So let's look at the epidemiology. So as you can see, since 2014, we've definitely had an increase in STIs, when you're looking at total syphilis, gonorrhea, and chlamydia. So you can see, a little dip in 2020, which we all know is when the pandemic occurred. And is that because people weren't getting tested, or was it because people were isolating and they weren't interacting as much? I think that's hard to determine. But then, of course, we saw a trend back up in 2021. And I think the biggest thing to note here is that the line for syphilis has definitely widened, and so our cases of those have increased over time as well. So why is the probability of first intercourse between 15 and 20? Why is this important? So this means that the onset of sexual debut is fairly young. So you can see that by about age between 17 and 18, about half of males and females have had their first intercourse. And so that's important because you have to think about when the onset of sexual debut is and the risk of them getting an STI. And so while STIs are probably treated pretty, fairly frequently in adult primary care offices and STI clinics and things like that. I think when we think of, sexual debut, onset of first sexual intercourse, if that's happening at 15, 16, 17, these might be cases that the pediatrician might capture. So it's important for pediatric providers to understand this information, be aware, and know that their teenage patients, there is a likelihood that their teenage patients are at risk for STIs. So if a patient presents, whether they present to a clinic or a primary care office or a pediatrician's office, it's important that you know why they might present. So some of the reasons that they might present would be, symptoms of an STI, known exposure to an STI, routine screening, asymptomatic testing. They might want HIV testing or PrEP services. They might need post-exposure prophylaxis or PEP requests. They might have concerns about partners' symptoms or behaviors. They might have this might be a follow-up visit. They might need a routine physical, or this might be a sick visit, whether or not it's related to an STI or not. So when you're collecting information, it's really important to have a welcoming clinic environment. It starts off as soon as the patient walks into the door. They're starting to form their trust as soon as they come in and check in at that desk. So you want to have a welcoming clinic environment. Your staff needs to be trained on a trauma-informed care approach because some of these patients coming in are not going to be as open and willing to share their information when they need help, or even if they're there just for screening, it is still important to have that trauma-informed care approach. You want to have a non-judgmental approach. You want to be open-minded, to know that not everyone has the same mindset as you. So if someone's behaviors do not align with your behaviors, it's important to have a non-judgmental approach, and open and welcome these patients into your clinic so that you can provide them with the best care, and they will be so much more open and trusting if you just have a non-judgmental approach. And you need to recognize stigma related to STIs. So if a patient is coming in, they're probably going to be hesitant to talk about their behaviors, their risks associated to STIs, because there is a stigma around it. If they don't want to be classified as someone that has an STI. So we really need to recognize that stigma and explain that, when we're open and we're honest and we trust that we can help them and we can get treatment for them, but recognizing that stigma is really helpful in getting patients to open up to us and be aware of your own biases. So, like I said, if your sexual behaviors do not align with someone else's, be aware of those biases. Check them at the door. Make sure that you're not having any type of bias when you're caring for these patients, based on your own thoughts and perceptions, because they will not open up to you and they will not be as honest when you're collecting that information, if they sense that you have bias in the situation. And then be aware of social desirability bias. So that is kind of like, the patient will tell you what they think you want to hear. So, for example, if you say, are you using condoms every time you have sex? Well, they're just going to say, yeah, because that's what they think you want to hear. But if you reframe the question and say, last time we talked about you attempting to use condoms more often in your sexual activity. Have you been successful with that? And that way you're not setting them up for failure to tell you something that they think you want to hear. They might be a little bit more open and honest and say, yeah, I've tried, but I just haven't been successful. Instead of just giving you a yes because they think that's what you want to hear. And when collecting your your sexual health history, it's important to remember the 5 Ps. So you have partners, practices, protection, past history of STIs, and pregnancy intention. So for partners, this is important to ask about the number and gender of their partners. And this is going to be specifically over the last 12 months. We need to find out if these are new or ongoing partners. Are these overlapping, or are these, are these relationships that have occurred at different times? Um, you need to define sex as any type of sex, and that's important because when you ask about sex, someone might just consider that to be um, like vaginal sex, but there's also anal sex and oral sex. So you need to be very open with your definition when you're trying to get this information from them. And then it's important to ask about your partner's partners. So not everyone has a closed relationship or a monogamous relationship. Some people have open relationships, or some people might have concerns that their partner is also has another partner. Or it might just be that they have a new partner who has had previous partners that they are concerned might have STIs that might be of concern to them. So it's really important to talk to them about their partners, current partners or previous partners, that it might also affect their health. Now, practices. So we need to understand the kind of sexual activities. How are they meeting their partners? And is there any concern for transactional sex? Because as we know, when there's issues of, or when there's concern for transactional sex, the risk of STIs do increase. But when you're trying to understand the kind of sexual activity that people are engaging in, it's really important to ask them and be open about something that you might not understand. So if they tell you that they are involved in a practice that you have never heard of, it is totally okay to ask them, what does that mean to you? To ask them, can you explain that to me? I haven't heard of that. Can you educate me on it? And that's totally okay. And patients are much more willing to open up to you when they feel like you want to know more, and you want to help them, particularly if you are doing it in a non-judgmental way, making sure that your biases are not affecting the conversation. And so protection. So what types of tools, prevention tools do they use, if any? How often do they use those? Again, so they might, if you're trying to encourage them to use condoms, um, maybe they use them with one partner but not with another. So it's important to ask those questions. And do they use them every time, or do they only use them sometimes? And it's not just condoms either. They might use different tools with different partners. They might use condoms with one partner. They might depend on PrEP or PEP with another partner. And then ask them about vaccinations. Have they had their HPV vaccine? All of these things are important when determining their prevention tools that they use. And so it's also important to ask them, what is their risk perception? So how do they feel about their sexual interactions, and what risk did they perceive? Because you might hear something on a surface level that they have identified a different risk that they haven't told you about yet. So if you ask them, what do you feel that there is anything that you are at risk for with your sexual activity? Then they might open up to you with something else that you had not considered based on that surface story that you got initially. And then what about past histories of STI? So do they have a history of testing, diagnosis? Oftentimes, if someone can't remember if they've been tested or diagnosed with an STI, you can ask them about treatment. Have they ever been treated for STI? And particularly if they've ever gotten an injection for it, that is helpful in knowing whether or not they've had a history of STIs, because people don't typically forget the injections they receive as treatment for STIs. You can ask them if they've had any reoccurring symptoms. So were they treated for gonorrhea or chlamydia and now they're having symptoms again? You want to ask about partner diagnosis and treatment. So had they previously been treated for syphilis, you could ask them if their partner had syphilis, if their partner was treated. You can talk to them about concurrent treatment. So if you are treating them or if you had treated them or someone else treated them, did they also treat their partner? And what is their partner's status? This is so important to know their partner's HIV status. So ask them if they know. Have they had that conversation with their partner? Do they know how to have that conversation with their partner? Because it's really important. If the partner is HIV positive and they are not, then there are other prevention methods that we need to deploy to ensure that they're as safe as possible. And what is their pregnancy intention? So this can be for males and females. This doesn't necessarily mean that is their intent to get pregnant, but do they have an intent to have children now or at some point in their life? Is there any chance of them becoming pregnant with their current practices? And is that what they want? It's, totally different situation if, you have someone who's trying to get pregnant versus someone who is not trying to get pregnant at this point in their life. But maybe that they don't, want to, they would like to become pregnant. And then we need to educate on the risk of STIs on fertility. And then talk to them about pregnancy prevention. So are they on any type of birth control medication? Do they have any type of implant that or IUD, anything that is preventing pregnancy at this point in time? And then you also want to talk to them about their sexual networks. So these are groups of people that are connected to another sexually. And I really like this image because it shows very well how two people can engage in sexual activity, but yet it just can spread out to other connections in a network. And so you can sometimes think about this to kind of a group of people. Say that a certain group of people tend to be on a certain dating app in a certain location. Now, this isn't always true for dating apps, but just as an example, if you have a group of those people on a dating app and they're looking to date or have sexual interactions, you can see that it would be easy to quickly have this network start to bud out if those people are frequently engaging in sexual contact with others on the app in a certain geographic area. So there's many different ways that you can look at sexual networks, but I just really like this image because it does point out how someone is connected to someone else, even if they may not have directly had sexual activity with that person. So let's get into the types of STIs. So we have chlamydia, gonorrhea, mycoplasma genitalium, syphilis, trichomonas, human papillomavirus or HPV, herpes simplex virus, mpox, and human immunodeficiency virus or HIV. So let's specifically look at chlamydia. So you can see that the rates of chlamydia from 1984 to 2023 really have just climbed. So in 1995, chlamydia was added to the nationally notifiable conditions list. You can see that small dip that we talked about from the pandemic. And interestingly, you would think that there would be that small dip and then it would bump right back up to the normal level, but we've sort of seen a dip and then it just sort of has kind of just stayed at that trend, at that level. So it'll be interesting to see as years go on what this data shows, particularly because we have some new methods of screening and more open communication and things like that. So chlamydia, from 2014 to 2023 has definitely has increased, generally over the decade. And you can tell the difference. I really like these maps because you can see, the lighter shading or the lower rates, and then of course the darker are the higher rates. And you can tell from 2014 to 2023 that there's definitely become more blue on the map and some darker blue. And interesting, particularly in the southern region, there is darker blue. So that might impact you and how you screen your patients. and things to look for, especially if you were, in the southern region. And so cases by age and sex for chlamydia. So you can see that the higher rates are really among females. But either way, for both groups, you have a pretty significant amount from ages 15 to 24, and then from about 25 to 29. So that's your kind of highest risk population that you want to consider when you're assessing your patients. So chlamydia is caused by Chlamydia trachomatis. It is a reportable STI. It is the most common. It is often asymptomatic with an incubation of 7 to 21 days. It does have a wide range of manifestations. For women, they can have cervicitis or urethritis. Men can also have urethritis or epididymitis. Both can have conjunctivitis, oropharyngeal infections, rectal infections, reactive arthritis, and lymphogranuloma varineum or LGV. So these types of manifestations also are something to consider when you're looking at the types of sex that these patients are having. So if they're having vaginal sex, if they're having anal sex, if they're having oral sex, the site of these manifestations are linked to the type of sex that they had. Some complications of chlamydia, particularly if left untreated, would be pelvic inflammatory disease or PID. And within PID, you can have fertility issues, ectopic pregnancies, tubal scarring, and chronic pelvic pain. You can also have perihepatitis, which is also called Fitzhugh-Curtis syndrome. And so this is inflammation of the liver capsule, and really is a result of untreated pelvic infections in women. So what are some testing options? So nucleic amplification tests, or NAATs, are really simple to use, and optimally, they're the most sensitive test. So if you look at men versus women or both, and you look at the sites at which you're testing, so for urethral, GC and CT in men, there is the option of a urethral swab, but really the first catch urine is optimal. For cervical, in women, the GC, CT testing, you could do a cervical swab, you could have a clinician-collected vaginal swab, but really the optimal option for this type of test is a self-collected vaginal swab. And we'll talk about this a little bit later in another module on self-collection. So the oropharyngeal GC, CT for both males and females. You could do a culture, but that takes more time. But the nucleic acid amplification, or the NAATs, that swab is actually the preferred. And so rectal, if you're concerned about rectal GC or CT testing, for both males and females, the NAAT swab is preferred over culture, and it is more sensitive and specific. So these are just the chlamydia screening recommendations. This is available on the CDC's website, and I really put it in here because it's nice when you're looking at it from the perspective of who is my patient, how old are they, what group do they fall in here. So you have women, you have pregnant women, men who have sex with women, men who have sex with men, transgender and gender diverse persons, and persons with HIV. So you can really refer to these screening recommendations to determine where your patient falls, to determine the frequency and like what ages that they should be screened and how often. So the current chlamydia treatment guidelines, it is important to know that chlamydia is a curable STI. The current treatment guidelines are doxycycline 100 milligrams orally 2 times a day for 7 days. The alternative to this, if they cannot take doxycycline, would be azithromycin 1 gram orally in a single dose, or levofloxacin 500 milligrams orally once daily for 7 days. Now, if the patient is pregnant, you would do azithromycin 1 gram orally single dose or amoxicillin 500 milligrams orally 3 times a day for 7 days. In chlamydia retesting, you would want to retest 3 months after treatment. And if they're pregnant, do a test of cure 4 weeks after treatment, and then retest again in 3 months. Moving on to gonorrhea, you can see that gonorrhea from 1941 to 2023, we kind of trended up and down, and then up again in the 80s, and then back down in the 90s and 2000s, and then starting to see an up in the 2010, 2011 time range, and then a little dip around 2020. Again, it'll be interesting to see more information on how the trends of gonorrhea change post-pandemic. But nonetheless, since 2014, gonorrhea has been increasing. You can definitely see the maps are different. There is much more blue, showing more higher rates on the right-hand side in 2023 than there were on the other side in 2014. So I just think this is a really telling map of where what gonorrhea is trending like since 2014. Looking at the cases by age and sex, slightly higher for males than females on gonorrhea, but truly the rates for females are also high. But again, the groups that you can see have greater rates are actually a little bit higher on the 20 to 24 and 25 to 29, and really from 30 to 34. That group of adolescents from 15 to 19 is still something of note, but you can tell that the age ranges are a little bit different for gonorrhea than chlamydia. So gonorrhea is caused by Neisseria gonorrhea. It is a bacteria which can infect the genitals, rectum, and the throat. Again, this is often asymptomatic, but when they do have symptoms, women often complain of dysuria, vaginal discharge, bleeding between periods. Men can also have dysuria, discharge from the penis. Their testes can swell and become painful. And then for both, rectal symptoms can range from anal itching, soreness, bleeding, pain with bowel movements, and discharge. Other manifestations and complications. So men can have epididymitis and other less common complications. Women can also have cervicitis, accessory gland infections, pelvic inflammatory disease or PID, can also experience that perihepatitis or Fitzhugh-Curtis syndrome. Both of them can have pharyngeal ocular symptoms, and then there can also be the concern for disseminated gonococcal infection, which can be very serious. And then there is the concern for perinatal infections with gonorrhea as well. So for testing for this is not unlike the last slide that we looked at for chlamydia. But again, for urethral in men, that optimal test is that first catch urine. For cervical in women, that self-collected vaginal swab is the optimal option. For oropharyngeal concerns, that NAAT swab is optimal. And then for rectal, for both, it would be the NAAT swab preferred over the culture because it's more sensitive and specific. Gonorrhea screenings, again, this is from the CDC. I just really like it because it can break it down by your groups of people, whether you have women, pregnant women, men who have sex with women, men who have sex with men, transgender, gender diverse persons, or persons with HIV. Interestingly, on this same screening recommendation, you can also flip this this chart, and the CDC will show it to you based on the type of STI. So if you just generally want to know all of the screening recommendations for chlamydia, you can look at it from that perspective as well, which I really like. So current guidelines for treatment, this STI is curable. This gonorrhea is curable. Now there is a concern of drug resistance, which we'll get into. But generally speaking, yes, this STI is curable. So uncomplicated gonococcal infections of the cervix, urethra, or rectum, you would do ceftriaxone 500 milligrams IM in a single dose for a person weighing less than 150 kilos. So that dosing will change if they're more than 150 kilos, which you can find that information in the CDC's treatment guidelines. But if they have a cephalosporin allergy, then you would use gentamicin 250 milligrams, again, intramuscular injection in a singular dose, plus azithromycin 2 grams orally in a single dose. Now, if they have a concurrent chlamydial infection or one has not been ruled out, you would also treat for chlamydia using doxycycline 100 milligrams orally 2 times a day for 7 days. And if they cannot take doxy, then refer back to the treatment guidelines for the alternatives. So this is where I wanted to look at the gonorrhea treatment over time. So if you'll remember back when we looked at that initial sexual STI treatment history timeline that we looked at in the beginning, we talked several times about how the treatment of gonorrhea changed. So you can see this graph, I really like it, from 1988 to 2022. You can see all the different things that we have tried to use and treat gonorrhea for. Now, the problem is that gonorrhea has become a very smart bacteria that has learned to become resistant to all of these different types of treatment. So you can see that primarily we were using penicillin to treat gonorrhea, which we talked about, and then we weren't. So you can see all over the place. We've had penicillin, we've used tetracyclines, ofloxacin, ciprofloxacin, cefixime, ceftriaxone 125 milligrams. Then we had ceftriaxone 250 milligrams. And then we started with gentamicin. And then the bulk of what we do now is ceftriaxone 500 milligrams. But then you have a small bit where we have ceftriaxone 1 gram. So it's interesting to see the changes in the treatment over time, and honestly a little bit scary when you're talking about gonorrhea drug resistance. So when you're looking at antimicrobial resistance, gonorrhea has shown resistance to almost all the antibiotics used to treat this, and the CDC considers this to be an urgent public health threat, so much so that it is under surveillance in the U.S., particularly with the CDC's Gonococcal Isolate Surveillance Project, or the EGISP. And this article is very timely. This is a new drug that has come out. This article was published on April 14th, 2025. And so this is looking at oral geptidiosin for the treatment of uncomplicated urogenital gonorrhea. And this is a phase 3 randomized open label non-inferiority multicenter study. And so this drug has shown to be effective in treating gonorrhea despite resistance to other antibiotics. So this is really exciting, and I'm interested to see how they move forward with this drug, but at least that there is something in the pipeline as we continue to study gonorrhea resistance. And then gonorrhea retesting. So we want to retest in 3 months after treatment. If they're pregnant, we test all women under the age of 25 and any woman over 25 with increased risk, and then retest them in the 3rd trimester. All right, so moving on, we're going to talk about Mycoplasma genitalium, or MGen. And so Mycoplasma genitalium, this is a non-reportable disease. So this is a bacteria which can infect the cervix, urethra, or rectum. It is more common in younger people and very often is asymptomatic. People can have dysuria, vaginal or penile discharge, and risks really include unprotected vaginal and anal sex. Really, there needs to be more research for oral sex. Complications of MGen, pelvic inflammatory disease, infertility, spontaneous abortion, and preterm delivery. So to screen or not to screen, that is the big question with MGen. So prevalence rates in the US are low, between 1 and 4%, but MGen resistance is increasing with antibiotics. So we really want to be careful because there's limited treatment options. So at this point in time, if asymptomatic, if they are not having symptoms, it is not recommended to screen. So you can test symptomatic persons, that is recommended. If they have persistent or recurrent cervicitis or urethritis, definitely recommended to test those folks. Now consider testing in the case of pelvic inflammatory disease, because as we saw, that is one of the complications. So it is something that you would want to consider in your PID patients. So testing options. MGen is a super slow growing organism and a culture can take up to 6 months. So the NIAT, like we talked about with gonorrhea and chlamydia, this is preferred and it is FDA cleared for the following samples: to have urethral, urine, penile, meatal, endocervical, and vaginal. And then a test of cure is not recommended for asymptomatic patients who have completed treatment. So it's very important to remember, if you've treated them, they are not symptomatic, you do not need a test of cure. Now, antimicrobial resistance with MGen. So macrolides. So the data show that about 44 to 64% of MGen isolates are resistant. With fluoroquinolones, ciprofloxacin and levofloxacin are not very efficacious. Moxifloxacin has a high cure rate, but still really only 89%, and that is dropping, showing us that we are having more resistance. So the current treatment guidelines for MGen, this STI is curable. So resistance testing should be performed whenever capabilities allow. And so not every lab does this, so it's important for you to check with your lab. But if it is macrolide sensitive, doxycycline 100 milligrams orally 2 times a day for 7 days, followed by azithromycin 1 gram orally initial dose, followed by 500 milligrams orally once daily for 3 additional days for a total of 2.5 grams. Now, if it's macrolide resistant, you would do doxycycline 100 milligrams orally 2 times daily for 7 days, followed by moxifloxacin 400 milligrams orally once daily for 7 days. Now, what if resistance testing isn't available? Well, then you're just going to go for the moxie. So you would do doxycycline 100 milligrams orally 2 times a day for 7 days, and then follow it with moxifloxacin 400 milligrams orally once daily for 7 days. Now, if there's an allergy, you would want to refer to your to the STI treatment guidelines. Now, management of sexual partners. There is a high concordance among partners with MGen. If the partner is symptomatic, test them if able. If you're not able to test, but symptomatic, if they are symptomatic, you may treat using the same regimen used to treat the partner, assuming that you check allergies. So some key takeaways here. Building trust as you take a sexual history is really going to be vital in gaining accurate information. So you want to follow the screening recommendations because these can capture those asymptomatic patients when appropriate. And Also, remember that increasing drug resistance is really a concern for STI treatment. So we want to be really careful in following the screening guidelines, following the treatment guidelines, and making sure that we're not inappropriately prescribing, because we really want to make sure that the drugs we're using are correct and effective to prevent further drug resistance, particularly for gonorrhea and MGIM. And then screening during pregnancy for STIs can prevent negative outcomes to the baby. So it's really important. You'll see that further in the next module, some other things that we need to consider for pregnant women and STIs. And these are my references. And I am excited to move on to the next module with you to talk more about STIs.
All right. Well, we'll be back for that one in 2 weeks. And that one is broken into 2 parts. I think it's a little easier to digest these things in smaller chunks. You can kind of let me know what your thoughts are, how you liked it. I thought it was really interesting to see, what's the latest on it. I know in our practice, a lot of the patients are coming in, and it's not with complaints of thinking that they have an STI. It's, some type of irritative voiding symptom. But we've always been in the habit of collecting 2 samples, sample 1, sample 2. And the one is, of course, that's that urethral wash. And a lot of times that's where we'll see, especially chlamydia, because you can kind of see that stringy, strandy thing in there. And that could be your first tip off. So, some of those things I noticed, if anybody else has anything, you can throw it in the comments as to what you're seeing. But I thought that's one interesting thing. Another part that I think that's worth mentioning is the keep in mind, they kind of showed those graphs of the younger folks, having these STIs, but there's been a real breakout in the nursing homes with STIs. And, it's probably a mix of the fact that Viagra, helps the guys to be able to perform longer into life than they used to. Plus, they're not worried about pregnancy, so they're tending not to use protection. And as we saw from that chart, one hookup can mean many hookups to depending on how many partners you have. So I hope you enjoyed this. I thought this was a great episode to, kind of kick off things. Again, next week we're going to be following this up with another episode, a different episode. We've got it's been amazing how many products have come out recently for prostate cancer, new treatments, and I've been really lucky to get a lot of these get some really great speakers to talk about these. And here's the one we're going to do next week.
Pluvicto is changing the landscape of advanced prostate cancer treatment, but is it right for you or someone you love? In this must-watch episode, host Vic Senese, RN, sits down with prostate cancer expert Dr. Siegel to discuss the real-world use of Pluvicto. We will discuss how it works, who qualifies, what to expect during treatment, and how it's impacting survival and quality of life. Join us on July 12th at 9 a.m. Central Time to learn more.
So be sure to join us next week for that. I think it's going to be a great episode. We look forward to learning more about it. Like I said, it's kind of amazing how many things have come around just recently. And I spent a lot of my time just trying to figure out what's new and exciting. So always join us next week. Let's just see if I got a comment that came in here. I did just recently. Very interesting as the antibiotic changes over years. Thank you. Yeah, Katie, welcome. So, yep. Hope everybody has a great 4th of July. It's a hot one this year in Chicagoland area. And I think we're all a lot of the country's under this high heat areas, but keep cool, keep safe, and see you next week.